Hi, I'm Dr. Heidi Silver, and I am the site PI for a study that's been going on here for a few months now on malnutrition. It's titled the Malnutrition Quality Initiative, and it's very interesting if we think about why malnutrition has come to the forefront of healthcare now. There's an article that was recently published by a nurse, Andy Melendez, and she titled it Role of Nutrition in the Discharge Care, Nursing Perspective. And she begins it by saying that nutrition has come to the forefront of healthcare, and effective nutrition intervention must occur across all settings and transitions of care. So my question to you today is, why do we wait? We always wait when it comes to nutrition assessment, identification of our patients who are malnourished or at risk for malnutrition, diagnosing malnutrition, and intervening. Why do we wait? She goes on to talk about current healthcare statistics reflect that malnutrition results in higher risks of infections, delayed wound healing, worsened physical activity, prolonged length of hospital stay, higher readmission rates, morbidities, mortalities, and overall healthcare costs. We know that from 30 to 50% of patients who are hospitalized either have malnutrition or are at risk. So why do we wait? She goes on to say that nutrition has not historically been prioritized, either in patient acute care or especially in discharge from acute care. And many patients are sent home with malnutrition, but no follow-up for intervention. This results in further complications, morbidities, mortalities, and readmission, and therefore healthcare costs. She talks about a poll that was given to nurses who attended the Academy of Medical Surgical Nurses Association National Convention in 2014 to determine current practices on nutrition, focused particularly at patient discharge from acute care. And she says that the results were alarming. 44% of the nurses who responded to the survey said that they do not consistently incorporate nutrition into the discharge care plan. 75% said that they do not have or know of any clear methods to identify resources for their patients for nutrition follow-up, or who to refer their at-risk patients even during their inpatient stay. And 84% said that they lacked adequate nutrition information to incorporate in the discharge plan. So maybe the answer to why do we wait is lack of information, and maybe there's many other reasons: lack of time, lack of understanding, other priorities. It's true that nutrition and malnutrition is not usually the number one problem on the list of problems or list of diagnoses for a patient admission. But it's also true that it's a major contributing factor to the quality of care we provide, to their outcomes, to their ability to function during and after discharge. So this is our last session in terms of our mini education sessions on malnutrition as a course of this study in particular. And I really want to leave you with this question: why wait? If we wait, does it benefit our patients, and does it benefit us as healthcare practitioners in providing good quality care to our patients and achieving the outcomes that we want to achieve? So I'm just going to remind you of some important information in terms of signs and symptoms of malnutrition. We've talked about these before, but in a nutshell, one of the things to remember is that malnutrition often coexists with dehydration. And so the signs and symptoms of malnutrition and dehydration are often similar. But in particular for malnutrition, we should be looking for poor appetite, inadequate food intake, fatigue or low energy level, weight loss, loss of fat mass, loss of muscle mass, loss of muscle function or physical strength or physical activity, fluid accumulation or swelling or edema or pitting edema, dull or brittle or loose hair, hair that's easily plucked out, dry, flaky, broken, or cracked skin, ridged, cracked, spoon-shaped, or pale nails. Those are the key signs that someone either has malnutrition or is at very high risk. More likely that they already have malnutrition. So let's keep in mind that 30 to 50% of our patients have malnutrition or are at risk, and yet medical diagnosis for malnutrition occurs in only 5%. There's a huge gap for us to fill, and nurses have a critical role in filling that gap. And finally today, I want to leave you with some information about the current state of malnutrition in our world here in Tennessee, where so many of our patients are overweight or obese. They do not appear malnourished. And so we really don't see the classic signs that starved, cachetic appearing malnourished patient. It's quite rare. Even among the patients that we expect would show signs of malnutrition, like our cancer patients. It's rare in those patients too. But the face of malnutrition today is more likely to be high body mass with other signs, especially loss of muscle mass, and that's known as sarcopenic obesity. It's very hard to identify physically. There are signs, and so we have put these laminated tools at the nursing stations on the various floors and units where we show you pictures of malnutrition and the anatomical sites where you could best identify loss of muscle mass, even in our overweight and obese patients. So I strongly encourage you to think about why wait. Thank you.